Hello everyone, today is 2nd of July. We have been doing this class on respiratory system examination. Today is the part 5 of this class. We have already covered the inspection part, the introduction of inspection part. Now we'll look at what is the first thing that you should look when it comes to inspection. That is the size and shape of chest. You need to comment on size and shape of the chest at first. Okay, so before going to the abnormalities, we must know the normal type. What is a normal chest? So normal chest, it differs depending on your age. If it's a child or an elderly, then roughly your transverse section it's circular. Okay, but if you are an adult, if a patient is an adult, then the shape is elliptical. Now, when it's an ellipse, we need to define its transverse as well as anterior-posterior borders. Okay, so this will be its transverse diameter and this will be its anterior-posterior diameter. So these are the two things which we need to define. So normally, what is a normal transverse to AP ratio? So normal transverse to AP ratio is about 7:5. So this is a thing that you should remember. Normal transverse to AP ratio. What else do we see in a normal chest? That it is a transverse with the transverse to AP diameter of 7:5 and it's symmetrical. Obviously, symmetry is very important when it comes to defining the normalcy of a chest. Also, the another important thing which we use to define a normal chest is the costal angle. So, to understand this concept of costal angle, suppose this is your sternum and these are your ribs. Okay. So the costal cartilages that form the inferior margin of the thorax or your chest cavity, these costal margins. So the angle between these two margins, the angle formed by these two margins, it's known as the subcostal or costal angle. Now usually it's around 90 degrees Celsius, not Celsius, sorry. Normally it's 90 degrees. It is, some say it is more acute in males. So a male chest will be like something like this, when you compare it with a female chest, where the angle will be a little more broad. Okay. Now, after defining how a normal chest of an adult, child, and elderly is, we will come to the abnormalities. Now, when we are talking about abnormalities, first we'll discuss about the symmetric abnormalities. That is, these are obviously abnormalities, but they are symmetrical on both the sides. We'll only talk about the important 3 or 4 types. Okay. The first type of it is known as emphysematous chest. Okay. This is the emphysematous chest, also known as barrel chest. Okay. So what are the characteristics? Here the AP diameter is equal to the transverse diameter. Okay. Then there are a few things that you should know about emphysema. Emphysema, obviously, it's an obstructive airway disease. So these are basically, if it's emphysema, it's a congenital or acquired condition. Or in obstructive airway disease, the other important thing that we get is a smoker's lung. So basically, these smokers or these emphysematous lungs, they are overinflated lungs or hyperinflated lungs. Okay. Now what happens is, you know that suppose this is a rib cage, and we all know that inspiration is an active process, whereas expiration is a passive process. So suppose this is normal chest, and suppose this is the chest of an emphysematic patient. Suppose this is the normal chest. This is how much it's inflated, and suppose this is the chest of an emphysematous or a hyperinflated patient. Now, what happens is obviously I'm talking in terms of a single lung and a transverse or on an vertical section of a single lung. So what happens is, see, if a if we compare it to a balloon, if a balloon is less filled with air, it is easier to inflate it. See, initially we'll need less resistance or less power to fill the balloon, but as it increases its size, the amount of effort that we need it increases. Similarly, think of an emphysematous lung. This lung is already hyperinflated. Okay, so this lung is already hyperinflated, and so to inflate this hyperinflated lung will need more energy. Okay, see the external intercostals and diaphragm, they're already working. So the more energy it will come, where it will come from? It will come from the accessory muscles. So along with the barrel chest, why do we call it as a barrel? It's like a barrel, the barrel of oil that we know. It's like a barrel. Now the other important thing is the accessory muscles, they are active in these patients. The inspiratory accessory muscles, you all know, they are sternocleidomastoid and scalene muscles. Also, they use shoulders. Shoulders are also used for inspiration. Now, how this happens is actually a body's adaptation. So they have usually broad shoulders. Then what they do have is a short neck and a thick neck. So these are the things which are commonly observed along with a barrel chest. What are the first thing? The first thing that we know is a accessory muscles are active, broad shoulders, and the third thing is a thick neck. So these are the adaptations that occur in the body in case of emphysematous chest. So the first abnormality, the first symmetric abnormality that we have seen in case of a chest is an emphysematous chest, also known as barrel chest. Now coming to the second type. Now second type is known as a funnel chest. Now what is a funnel chest? See, it's also known as a cobbler's chest. Now a very strange thing happens over here. Suppose this is your anterior side and this is your posterior side. Okay. Suppose this is your normal chest. Okay. Suppose this is your normal chest. Now what if this Zifi sternum and anterior part of your chest, what if it goes in like this? What will happen? Your chest will become something like this. This will be your anterior part and this will be your posterior part. So basically there will be a hollow or a kind of a fossa created anteriorly on your chest. Okay, so this defines your cobbler's chest. Now why do we call it cobbler's? We'll get to know that in a second. Okay, so first thing uh, is that there is a hollow or a fossa created anteriorly on, on your chest. Now what are the causes? See, sometimes they are just, what do we say, they are of no significance in some patients. Okay, sometimes they are just hereditary, familial or hereditary, but as long as, I'll tell you one thing. The second thing is occupational. So for understanding this, I'll tell you an example. Suppose there is a person, what he does is he regularly does shoe polish. Okay, he shoe polishes his shoes of other persons. Now what we see right now is, if you want to get your shoe polished, you go to a person and he has some kind of instruments with him. So basically what he has a brush and he has a some oil. Okay, and what he will do is he will take your shoes, right, and he'll keep it on a table or something like this, whatever the mounting part that he has, he'll keep it on the table and he'll just rub your shoes. But this is not what used to happen, suppose around 100 years back. So what 100 years back was used. So see, shoe was a privileged, what do we say? Shoe was a privileged thing to wear, no? Not everyone used to wear shoes. So what these rich people they used to do is they used to put this shoe over the chest. Yes, you heard it right. They used to put their shoes on the chest of a person who is going to polish their shoes. So now imagine if someone is putting a shoes on your chest for like every day since you are young for 40 years, obviously this part will go down. Okay. So this is why these cobblers or the shoe polishing guys they used to have this deformity. So that is why we are calling it cobbler's chest as well. Okay. Now second thing is occupation you understand. Sometimes it's hereditary or familial. The third important part is so suppose if a child has a rickets. Sorry. Suppose if child has a rickets in its childhood. So obviously his bones will be fragile and any kind of shear, and tear can cause this deformity. So if a child has rickets, obviously he'll have what do we say? Weak bones, right? So he'll have weak bones. That is why this kind of deformity can be seen. Now, sometimes, as I have told you, in some patients, this abnormality is seen, but it is not significant. Then when is it significant? So this is a very important statement. This is significant only if it compresses the underlying organs. Okay. So if it's compressing the underlying organ, then only it's of any significance. If it's not, then it's just a artifactory finding. Okay. Now, without any further wasting further time, we'll come back to the third part, a pigeon chest, or the medical term used to describe this is called as a pectus carinatum. Okay, so this is a chest which is opposite of a cobbler's chest. That is, this is your anterior part, this is your posterior part. So anteriorly, the chest will be protruding like this. Okay. Now sometimes they say that it's like a ship, the frontage of a ship. If you see the frontage of a ship, it's like this. So they also call it a what do we say? Keel, keel of a ship. It looks like the keel of a ship. Okay. So what are the conditions? Similarly, like in case of cobbler chest, the conditions will be quite same. First will be your hereditary. Okay. Second, quite easy, childhood rickets. Then, if there is any kind of nasopharyngeal abnormality in childhood. So what happens is actually when you have a upper respiratory tract obstruction, you will have some kind of inspiratory issues. Lower respiratory tract obstructions they cause expiratory issues, and your upper respiratory tract issues they cause inspiratory issues. So what happens is if you're not able to inspire, the air that you inspire it will be less, and also at the same time if there are some nasopharyngeal abnormalities, the expired air will also reduce. So you will have some retained air. And imagine it in your young age, if you are retaining more amount of air in your chest, your body will try to accommodate the increased amount of air. So it will give rise to this kind of abnormality. So these are all, what do we say, the adaptations of body. Okay. So these are the important causes. Now another last thing that I want to know, I want to tell you all in this type of chest is it's a chest that is seen in rickets. So see, basically, you can get a cobbler chest in rickets. You can get a pigeon's chest in ricket. Okay. So what are the other types? So to enumerate once more. So what are the conditions that you can get in a chest in a rickets or a ricketic chest? As far as the rhachiatic chest is concerned, first is the pigeon chest that you already know. Second is your keel breast, that is a pectus carinatum, right? Third thing that we use is Harrison grooves. Now this is important. So what are Harrison grooves? These are horizontal transverse grooves from the side of sternum which go laterally and giving appearance of a transverse constriction around the chest. See, I'll draw an figure for you. See, this is your chest, this is your neck, okay, and this is your diaphragm, this is your abdomen. Okay, so this part is your coastal margins. We'll draw it another color. So this is your basically rib cage. Okay, so these are your coastal margins. So what happens is this Harrison groove, it runs laterally from the sternum and it gives an appearance of a constriction band over here. So this part will be like this. The lower part will down will be normal. So this will be a hollow transverse groove which runs along the coastal margins and also gives an appearance of a constriction band along the lower part of thorax. So this is a finding that we get in a patient of rickets. Okay. The fourth part, these are something called as rosaries. Okay. So what happens is at the junction of costochondral joint, this is your sternum, these are your ribs. So these costochondral joints they get enlarged, okay, and they give a beaded appearance. So we call them as rosaries. Okay. So these are the four findings that we get in a patient of rickets. These are just things that can occur. Now the simple and last part, asymmetric abnormalities of chest. The four types of chest that we have seen above, they are symmetric. Okay. Now these are the asymmetric abnormalities of chest. Now any kind of spine abnormality. So imagine this is a patient's spine and these are his lungs. Okay, and this is the overlying chest. Now imagine if this spine is tilted like this. Obviously this part of lung will be compressed and this one will expand. So these will lead to a curve and you will get an asymmetric abnormality of chest. So if you must look for a spine abnormality. So the important cause of asymmetric abnormality of chest or chest shape is spine abnormality. Secondary, you can get, suppose this is your normal chest. Now imagine these are your ribs, okay? So now if this side of lung is normal and you see a bulge over here only this part. So what do we suspect? This chest is normal, this side of chest is normal, but this side of chest it looks bulged. So there must be something inside the lungs or something inside the pleura or something on the chest wall that is causing this bulging. So what are the important causes? First is a pneumothorax. So imagine some kind of air, it gets accumulated inside here wall, it will cause bulging. Okay. The second important thing is pleural effusion. So there is increased amount of water inside your pleural spaces. First we had increased amount of air, then we have increased out of water or your fluid. Second is an abscess. So if any kind of infection is there inside your lungs or inside your pleura, there will be a bulging. Okay. And what if we replicate this diagram over here? Okay. What if we replicate this diagram here? And what we see is instead of a chest bulge, just a second, I'll draw a diagram. What we see is instead of a bulge, what we are seeing is a retracted part. Okay, this is what you're seeing, a retracted part. The rest of the lung, it appears normal. So now what can be the cause of retraction? It's also an asymmetrical abnormality. So there must be something inside which must be pulling it, pulling your pleura, and the pressure will be transmitted to your chest wall and it gets pulled along with pleura. So what are the things that can pull it? First is your, first and foremost is your lung collapse. Imagine if it's a balloon and if it gets collapsed, it will shrink. So similarly, this if this lung gets collapsed, it will pull the pleura and chest wall inside. So lung collapse. Second is a fibrosis. Imagine there has been a serious infection like tuberculosis inside this lung, and now this infection it has resolved. But what it has left is its scars. Now the scars will pull the above with pleura and chest wall along with it. So lung collapse and fibrosis will cause unilateral retraction. Okay, so we'll quickly revise about the abnormalities and the chest shape. So normally a chest of a child or elderly will be circular. Adult will have a transverse or elliptical. Now this transverse to epidiameter, it will be of 7 is to 5 ratio. It will be symmetrical. Coastal angle of around 90 degrees. Okay. First abnormality, which is a symmetric abnormality, is emphysematous chest. Okay. Seen in smokers or emphysema. Overinflated lungs. Therefore, to inflate a overinflated lung, you need more energy. Therefore, there will be accessory muscles active. There will be shoulders are also used for inspiration. So broad shoulders and thick neck. This is how you identify emphysematous chest. Second is a cobbler chest, obviously a anterior hollowing. A third is a pigeon chest. Both of these are seen in rickets or the funnel chest related to occupation. And a pigeon chest may be seen in some kinds of nasopharyngeal obstruction in childhood. First, final is your total, which are the different kinds of abnormality ricket chest. Pigeon chest, keel breast, we have talked about. Harrison grooves, these are transverse constricting band, hollow. Then your rosaries. Now, asymmetry, when it comes to the asymmetric abnormalities of chest, first will be your spine abnormalities, which will give rise to the your asymmetric abnormality. Second, it can be unilateral bulge, or it can be a unilateral retraction. Okay, so bulge will be due to pneumothorax, pleural effusion or abscess. Your unilateral retraction will be due to lung collapse or fibrosis. Okay, so we'll stop for today in this part 4, and we'll see you in the part 6. Thank you.